Okay, so this is a 17-year-old boy which had come to me. I think this is one of the cases which I had operated 11 years back. You see the X-rays, they show all the signs of dysplasia, which I was talking about, spina bifida occulta with a hypoplastic L5. And a farmer by occupation, low IQ. Patient came with back pain and leg pain, bilateral leg pain. And the classical Fallon-Dixon sign was present. And patient was not very affording. So I did a conventional T-leaf, but instead of using a cage, I inserted a tricortical iliac crest bone graft. So this is a tricortical iliac crest bone graft which I harvested from the ipsilateral side of decompression. And this is a 1 month post-operative X-ray pictures, all well, everything doing well. And the patient patient was mobilized immediately within next couple of days. And see the post-operative X-ray at 6 months. The patient came back to me after 6 months and with again back pain and some leg symptoms on both the sides. The X-ray showed that the listhesis had reoccurred and it was progressing, and the S1 screws were broken on both the sides. Patient was advised revision surgery, but the patient was advised revision surgery, but the patient did not
I
undergo.
request somebody who has two devices on to shut down one device, please.
Yeah. Hello. Yeah.
Please
Hello.
go ahead, Pramod.
Yeah. So these are the X-rays at 6 months. You see that the screws, both S1 screws are broken and there is progression of the slip. The patient was advised a revision surgery immediately, but the patient refused as he was not that affording. And the patient kept follow-up after like 2 years. And this was the condition. You see almost a spondyloptosis of L5 over S1. And what are the options in such cases? So how do you go about it? And the leg pain in this case, it had worsened severely. We did a CT scan and we saw that the L5 screws, they had already eroded the medial margins of the L5 pedicle, and they were rubbing against the L5 nerve root, which was the cause of the leg pain. These are the CT scans. You see that the listhesis is progressed. It is not correctable rigid deformity and increased back pain. So I went in again, revised. Again, the problem was salvage of those L5 screws, and which Dr. Appaji had rightly mentioned that if you don't get a good hold at L5, then don't try to attempt the reduction completely. And I tried to get a new insertion point for the L5 screws more laterally from the base of the transverse process. And I was able to get good hold at one side and not so good hold at other side. And we supplemented with L4 screws and the iliac screws. This was 2 years after the first surgery. The second surgery, I think, was done in 2011 or so. And patient became all right completely. Again, I think after 5 or 6 years from that, the patient again came back again with some kind of back discomfort. And you see that loosened top nuts of the iliac screws. So what I did here was we did a CT scan and we saw a solid fusion out there. We saw a good fusion with a cage in place and no aggravation of listhesis. And I just went in and removed those iliac screws along with the top nuts, and the patient was asymptomatic. So this is the final post-operative follow-up after those 2 surgeries. So I think the moral of this story is, first of all, don't compromise with the initial instrumentation when you're operating these these supposedly high dysplastic listhesis. Because in the first place, if we had inserted a good interbody cage, then probably this problem would have been avoided. And secondly, revision of those fired up L5 pedicles is really, really very difficult. And you have to have a backup plan for that. And ultimately, I think I contradict what Dr. Appaji was telling, that in such cases, I think it is better to go ahead and supplement with those L4 screws and the S2 AI screws, or maybe the iliac screws to get a stable fixation.